Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. FNS On Air is brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine.
Hi, everyone, and welcome back to another episode of FNS Unplugged. As always, I am your co-host, Pietro Bortoletto. And today the tripod is actually a tripod. I don't know what the chair. Normally there's 4 legs to us. Today we're down to 3. Blake is fortunately or unfortunately busy doing prospective randomized research. Sounds like the University of Oklahoma is participating in a surgically minded trial that maybe he'll tell us about one day, and he was asked to come help out with the procedure. So he's doing bigger and better things. It's fine. I think we'll survive without an FNS Reviews article this month. We'll get to it next month, is what I'm trying to say. But we do have, as always, Daylon James and Molly Cornfield with us. Hey, guys, how are you?
I'm doing great. You guys, I remember I missed a show a couple months back and heard that it was the most rapidly and aggressively downloaded episode ever. So
nary a mention of a mouse model.
Exactly. I'm the weak link. I'm afraid that this episode might be the least downloaded because Blake, he's a real leader. And
who doesn't love a good review article?
Yeah, well, Blake has a good social media presence too, so you have to make sure he promotes our episode.
That's right.
He's not on it.
Well, notwithstanding, we have lots of science to talk about. The last podcast, I think we introduced the concept that Molly and I are switching roles. Molly has a battlefield promotion. She's now media editor for FNS Reports. And as such, Molly, tell us about your article this month in FNS Reports.
Great. Thank you, Pietro. So I'm continuing on my PCOS theme from last month. The article I picked today from FNS Reports is Lack of Adequate Counseling About Pregnancy Complications in Patients with Polycystic Ovarian Syndrome, a cross-sectional survey study, with first author Ann Kim and last author Anuja Dokras from University of Pennsylvania. So PCOS, as we all know, is a really common condition, affects 8 to 13% of reproductive aged women. And in addition to reproductive considerations, which we're all very aware of, has associated medical complications, including cardiometabolic risks and psychological risks. PCOS is also associated with higher prevalence of obstetric complications, including gestational diabetes, preterm birth, C-section, and pregnancy loss. But patients may not be getting this preconception counseling and either may miss opportunities for medical optimization or feel unprepared when obstetric complications arise as a result of this. And in fact, only 31% of OBGYN residents were aware of the association of obstetric complications and PCOS. So I think it's pretty likely this counseling is getting missed. So the authors of this study, to kind of investigate how much this counseling is happening, designed a survey study of participants with PCOS who had attempted to become pregnant or had been pregnant. And they actually distributed the survey through PCOS Challenge, which is a patient support group. So I suspect that the participants in the study might actually be a little bit more educated in general about their conditions since they were already seeking out and becoming involved in a support group. On the flip side, the authors suggest that the participants who are in a support group may actually have more negative experiences with the healthcare system, and that led them to seek out support groups. So that's another way that this data could be a little biased, but I do like this support group catchment for the study. The survey was developed with a multidisciplinary expert advisor group, and I thought what was also really unique is that they involved members of the PCOS Advisory Board, which had 30 patient advocates. I think that's really unique, and it's great because you can make sure that you're really using language that patients understand, language that's patient-centered when you're designing these surveys. So they don't know their true response rate. I think tens of thousands of people are part of this support group and on the email listserv, and they just received over 300 responses. So you don't actually know how many people opened that email and looked at the survey. So potentially a low response rate. The majority of the respondents were aged 26 to 35, white at 79%, and obese at 74.8%. So you can see these demographics are really different than the PCOS study that we all talked about last month, in which actually almost 100% of the participants were Hispanic. And so this survey just really doesn't apply to all of our PCOS patients, but would apply to a subpopulation of them. And many of these patients had associated comorbidities that we traditionally associate with PCOS. 36% had hypertension, 45% had prediabetes or diabetes, and 83% had anxiety and depression. And 72% had been pregnant, and the remainder had attempted pregnancy. And of those who were pregnant, 66.8% reported a complication in their pregnancy. So regarding the counseling specifically, more than half, 52.7%, reported that they were counseled on PCOS and the associated complications prior to their pregnancy. The remainder reported no counseling, so just over half. And more specifically, only 53% were counseled on weight management. Somewhat concerning is that for patients who had a hypertension diagnosis, only 25% received guidance on management of their hypertension prior to pregnancy, and only 47% of those with prediabetes or diabetes. So we're doing better for the diabetes patient, but we could definitely have room for improvement for the patients with hypertension. A caveat is we don't really have the timeline for this study, so it could be that they didn't have a pre-existing hypertension diagnosis at 25, and they're doing this study 10 years later. Also of note, 40% of those with anxiety and depression did discuss their mental health prior to pregnancy. And I think notably, patients who utilized fertility medication to conceive, so our patients, were more than twice as likely, so 59% compared to 25%, to be counseled about pregnancy complications related to PCOS, which I think makes a lot of sense. So we're more likely to counsel in the preconception period when we have an opportunity to change outcomes. And I think that's actually a reassuring finding. You know, we're seeing these patients right before they're getting pregnant. Now we're intervening or at least counseling about it. But of course, an 100% rate would be better. There's a lot more detail in the text about which patients in particular were more or less likely to be counseled and more or less likely to be satisfied by that counseling. And I encourage you guys to check that out. So I think we can all agree it's also possible that some patients were counseled, but totally forgot. And amidst all the information you get during a preconception visit, a fertility visit, early prenatal care, they might have just forgotten that and not remembered. But I think what's important is whether they remember it or not. So if they're not remembering, it's almost as if the counseling wasn't done. How can we make this counseling more impactful, more memorable? So how would we improve on this? I think the most telling statistic is from the intro, where they said 31% of OB/GYN residents aren't aware of increased OB complications with PCOS. They're the ones managing these patients on labor and delivery. And so I think starting with trainee education is definitely a great place to start. I think the best time to do this counseling, maybe when the PCOS diagnosis is made, to at least kind of introduce the idea that, hey, you might have higher risks of obstetric complications. When you're ready to try and conceive, come back and talk to me first, since despite PCOS, some of these patients are just conceiving on their own. And I think, of course, the most essential time to counsel is when you see them at that preconception visit. And in our specialty, for patients who are coming to see us to use fertility medication, I think we're all trying to screen and optimize these patients as much as possible. And we aren't doing terribly in this study. We had 59%, but there's still room for improvement. I think as much intervention as we can do upstream, definitely the better. By the time the patients sometimes walk in my door, especially if there was like a 3-month, 6-month wait to get into our clinic, they're ready to go with fertility treatments. They may not be as open to discussions about how we might medically optimize them, though we're still going to have those conversations, but there might be more resistance, which is understandable. Most of us won't proceed with fertility treatments unless diabetes and hypertension are really optimized. But I think for obesity in particular, there's a lot of potential for pre-pregnancy optimization. And then kind of bouncing off a big bounce from this study, I think a great area for future research is how we can optimize these patients best, especially in terms of obesity. I've seen a couple studies on using like a short-term time period of GLP-1 agonists, 3 or 6 months, and having this rapid weight loss and then stopping them prior to conception attempts. And the benefit being we improve fertility rates because they'll respond better to letrozole. Another plug to last month's study when we talked about BMI and letrozole, and then hopefully improving those pregnancy outcomes, reducing complications, but we don't really have the full data, the full picture on that, whether that would be an effective approach for PCOS patients, but that's definitely a great area for future research. So, and then the authors also point out expansion of PCOS specialized providers and clinics could improve this. And I think that's a great point, but what do you guys think? What you take away from this article? What would you look into next?
First, a quick question to you guys, the clinicians, from me, the scientist, who doesn't have that patient-facing interface as much as I'd like it. What is like the end game of this type of paper? Is it like, here, we're taking the temperature of like whether or not we have adequate counseling in this group of patients, and in this case, it seems like not? Or is it like I wouldn't say a mandate, but are there enough of these papers documenting that deficiency and then it gets incorporated into, I don't know, like up to date or something, or into the training mechanism? What do you think is how do you act on this kind of story?
I think, Dalen, these papers, particularly from this really powerhouse group at Penn, is kind of identifying the problem, putting data behind this thing that we kind of all know happens. And I suspect it's probably going to lead into a grant funding opportunity where they can say we've identified a problem, and some of it is going to be tackled with patient education tools and shared decision-making tools, and please pay for it, is my suspicion. But I think the other part of it is, it gets us to talk about it, right? Like, we have now talked about it on this podcast where we have over 1,000 downloads for each episode. So we've reached 1,000 additional people by nature of this article having been published in Fertility and Sterility. One comment that I had, Molly, for you, and like, what do I think about this paper? As you were kind of telling me about it, the thing that I kept thinking was, we do a really poor job as subspecialists communicating back to OBGYNs what's happening in our office, right? Like, we get them pregnant, then we send them with their records so that they know when their LMP was and they can come up with their due date. But there's a lot that's lost in between. And I think if we paid a little bit more attention to that last note, or that initial H&P when we have a diagnosis, and it's easy as putting together a dot phrase with, like, what are the things that everyone should know about PCOS, both the patients, since again, remember, patients can read our notes now in the modern era, but two, the doctor on the receiving end, the nurse practitioner on the receiving end can also read it and be educated. And I've done a pretty careful job in my documentation to try to come up with problem-based dot phrases for this exact scenario, because I think it's an opportunity for education, but it also joggles my memory. So when I have that patient in front of me, I can say, PCOS, dot PCOS. These are the things that you should know about. You should know about the risk of hypertension, gestational diabetes. You should know about all of these pregnancy and non-pregnancy related things. So when it keeps me honest, keeps me consistent, but ultimately, I think serving the point of educating someone else with my documentation.
That's great to educate back. And then also the residents in our clinic pick up on that too, or then they're seeing them in prenatal care, and we're kind of educating the next generation on that as well. So I think anything that can be automated is great. So PCOS diagnosis, automatically attach this dot phrase. But I think you also make a good point about, okay, we should explain how we optimize the patients prior to conception. Oh, actually, we did metformin, or she saw the nutritionist and we got her A1C way down prior to attempts. And I think that clinical context is really important to convey to the OB provider that's taken over.
That's exactly it. Well, this is it's nice to have some data to support what we all think, and kind of feel that we could probably all be doing a better job collectively.
Not to call anybody out, do you think there's a disparity, in terms of certain practices versus others? Maybe a more educated patient versus less. Is there a demographic component to this? Any ideas there?
I think there are definitely places that are kind of centers of excellence for PCOS care. I think of the University of California, San Francisco REI division that has a PCOS clinic. I think of University of Pennsylvania, Yale. I think a lot of us are dealing with PCOS, but maybe don't have kind of the infrastructure around it, where you have psych counseling, you have an endocrinologist, you have obesity medicine kind of also caring for these patients. I think that's a aspirational goal for a lot of people. All right, well, we have to move away from reports, and unfortunately, we have to talk about the science, Dalen. And I use unfortunately loosely. I shudder at the thought that there may be a mouse model that's talked about today, or a tissue culture system. But rather than me kind of ruminating on that fear, why don't you just tell me about this month's paper from FNS Science?
Have no fear, Pietro, Molly, listeners, Blake, wherever you are, saving things. This isn't a mouse story. I got a story. It's a big picture story, and it starts with the first IVF baby. Remember that, guys? You were just a glimmer in the eye. July 25th, 1978. I was actually 4 months old, dating myself there, but that's a big date in the history of reproductive medicine, of course, but it was also a watershed in the history of science, medicine, everything. Because it was the first reconstruction of human conception and pre-implantation development outside the body. While that resulted in like a whole maelstrom of debate across bioethical, religious, political, medical landscapes, residue of which we're still feeling today, IVF is now commonplace, right? And it's supported across a broad spectrum of leadership and constituencies, right? But that watershed, taking human biology ex vivo, especially at the level that, a profound level as the beginning of life, that really kicked open the door to a whole range of medical possibilities that continues to expand and drive innovation across a wide range of technologies. We're talking micromanipulation, microfluidics, microscopy and imaging, genomics and genetic counseling. I mean, the list goes on and continues to grow. And today I've got another addendum to that list. I'm sharing a story about sperm, which is arguably, I guess, the less fawned upon gamete to the ART community, and perhaps justifiably given the seemingly inexhaustible capacity of spermatogonia to generate functional sperm throughout a typical male lifespan. But you guys know, male factor has a role in maybe half of all IVF cases, and overcoming the challenges to male fertility, whether they be related to preservation of fertility in these onco patients or pathological male factor, it's of increasing interest. Specifically, we're talking here about non-obstructive azoospermia. And given that, I thought we'd start with maybe the existing clinical standard. Either you guys want to share the current state of the art when you're dealing with a tough NOA patient?
So the state of the art is microtesting.
Yeah, Tessie's cool and all until you have to actually be the patient who has to undergo this big exploratory procedure. I'd be game for spermatogenesis method, where you can do ex vivo spermatogenesis.
Yes, Pietro. Although your position there is clearly biased by your XY status, but I think it's also true, and not only the discomfort and challenges, personal challenges and resistance to that approach. It's limited. It takes an amazing operator to actually identify these single sperm. This isn't just like a testicular biopsy and then shoot it in IUI. You have to identify the sperm for ICSI there. So yes, it's a challenge in many respects, although it's commonplace as well. And that's the clinical standard. But as you're alluding to, Pietro, here at FNS Science, we're sharing innovations that drive the clinical standards of tomorrow and also appease the fears and dread of all those XY bias people out there. So here from Ryan Flanagan's group at the Vancouver Prostate Center, we've got a story that kind of circles back to those early days of ART in the late 70s with potential to take spermatogenesis ex vivo, as you said, Pietro. And the rationale for the study is that non-obstructive azoospermic testes often contain spermatogonia, but the environment of the testis can't support all of the stages of development and maturation that culminate in a haploid spermatid that can be utilized for ICSI. But what if you could work with something part way along the path, right? Say a spermatocyte, for example, which has commenced meiosis 1, but still has a leptotene, zygotene, pachytene, diplo, all the teens stages before it's haploid, right? Oocytes can finish meiosis in vitro, right? So why not spermatocytes? Well, there are a few things that need to be worked out before we get there. Most critical among them is that we need to reconstitute the matrix and signaling environment that's present during spermatocyte maturation. But in order to establish the methodology along those lines, the first step is to provide a means of enriching for this population, that target population of spermatocyte, from testicular biopsy so that they can be isolated, analyzed for scientific purposes, and ultimately matured ex vivo and used therapeutically. This paper established an important tool toward that end, because even though histologic and molecular analysis of testis has exhaustively characterized the stages of spermatogenesis, there are no well-characterized molecular markers that are specific to early meiosis onset and this is key, localized to the cell membrane. And the reason why that cell membrane localization is critical is because that enables a non-destructive labeling and thus sorting of live cells. Here, Flanagan Lab utilized single-cell RNA-seq data, RNA sequencing data. That's where you get an entire transcriptome from individual cells of the human testis in this case. This was a publicly posted repository, or was data publicly posted in a repository. And they used that data set and did their own analysis to identify candidate markers that were cell surface localized. They then validated the specificity of those markers for a stage of spermatogenesis around the leptotene or early leptotene stage, which is the first of those teens, and utilize antibodies and fluorescence activated cell sorting to purify this population to a very high degree of purity. Now, of course, there's a long way to go to reach haploid spermatids. Essentially, you got to go through all those teen stages there in order to use something for ICSI. But a key to that will be the close analysis and in vitro experimentation using this approach, using these markers to isolate early stage and then subject them to all manner of testing and stimulation experimentation to see how far along the pathway we can take them towards something that's clinically useful. As I said, it's a long way before we're going to be using that ex vivo process to generate sperm, but it might be sooner than you think. And this also dovetails well with a lot of current exciting research that's generating spermatogonia, or spermatogonia-like cells and primordial germ cell-like cells from pluripotent stem cells that can be derived from patients who have truly they could have zero testis even, and still conceivably generate spermatids from their own skin cells by way of a pluripotent intermediate. So a lot of exciting possibilities here, and an essential tool set, I would argue, toward getting toward those long-term goals. What's your guys' take on this human study? I'll remind you.
For the ones of us who have done less flow activated cell sorting, can you dumb it down for us and explain what you need to do to be able to sort cells, and how do you actually sort cells?
So anytime you're working with a population of cells, you got to dissociate them in order to sort them into a single cell suspension, right? And a lot of the markers that we know for the specificity of cell types in the testis are transcription factors or intracellular proteins. When they're localized to the cell surface, antibodies that are specific for them, specifically when they're localized to the extracellular component of a cell surface protein, those are visible, right? Those are on the outside of the cell. So in the single cell suspension, while they're still alive, you can get antibodies to bind to them. Those antibodies can have beacons on them that you can run through this laminar flow microfluidic device called a cell sorter, where one by one, you can deflect on a nanosecond scale. You can deflect these cells in a stream going about 5,000 cells per second, you guys, and you can deflect these with a high degree of specificity. But the key there is that you need to have a marker on the surface of those cells so that when you label them, you don't have to permeabilize them to get the antibody inside the cell. Because of course, permeabilizing the cells, all the stuff inside the cell is going to leak out once you poke holes in the membrane. So that's the key here, is finding a cell surface factor seemingly so mundane and basic and like an assumed, something that is a component of all hematology and many other subfields that look at different tissues, but in the testis has been lacking. So it's a small incremental advance, perhaps, but I think this is a tool that's going to be widely used in any approach that looks to dissociate testis and then specifically enrich for this early meiotic time point and cell type.
Is the act of sorting in and of itself destructive to that cell?
That's
like, do you lose the integrity of that cell once it's sorted, or you just kind of putting it in bins and then you can still do all the normal stuff with it?
The viability is surprisingly good, and it's also cell type specific. The real key there is your methodology, right? The testis, there's a lot of enzymatic dissociation involved. There's a lot of treatment there, and the conditions under which those cells are treated and enzymatically dissociated can be stressful and can lead to significant loss in viability. But it's all within whatever levels of tolerance you've established. And at the end of the day, you do get live cells. And this is a process that has been widely used, particularly in the field of hematology, demonstrating full retention of the functional capacity and differentiation potential of stem cells in the blood, at least. So I think it's something that could be applied in the testis while retaining the functional capacity of those cells. The other problem is how we're going to get them to move along that path. I think that's going to be a much bigger problem, but you got to start somewhere.
And I hope that this research can also contribute to efforts for using testicular biopsies for like prepubertal children getting chemotherapy. I think there's some promise there to contribute to the research. So lots of things it can help with.
That's a brilliant point, Molly. In the field of fertility preservation, the idea of freezing tissue, a chunk of tissue, can be really damaging, and recovery of that tissue is a major challenge, both with testis and ovarian tissue cryopreservation. But what we've learned both from cryopreservation of oocytes, gametes generally, as well as embryos, as well as cord blood, is that single cell suspension and the right cryoprotectant is the best way to maximize the viability of that tissue, slurry post thaw. So I think that's a really great point, Molly, is that this is a means to pre-process that prepubertal tissue in order to maximize the retention of those cells and their usefulness on the back end. Again, though, how we're going to get them to turn into sperm, I think, remains a major question.
Well, this sounds like science for science's sake, and that in and of itself is cool. So kudos to Ryan Flanagan, who I know is a former Cornell male infertility fellow. Lots of great male infertility research coming from the Cornell alums. I get to round out the podcast this month putting on my Consider This hat, which is always kind of fun. And I have a pretty non-traditional article, something that's kind of just easy and fun to talk about. This article is entitled Diversifying the Future, Analyzing REI Fellowship Websites and Their Diversity Statements in Comparison to Other OBGYN Fellowships, by first author Kyle Lee and senior author Ruhi Jalani. So the authors here wanted to investigate diversity statements on REI Fellowship websites and compare them to other OBGYN-related programs across different geographic regions in the United States. The way they did it was actually really straightforward. They looked from the time period of March to April 2023. They looked at REI fellowships and the other ACGME accredited fellowships, MFM, Urogyn, Family Planning, and GYN Oncology. The authors reviewed the content of these websites in pairs, and they tried to identify and assess the presence of a diversity statement that was located on the website, but then also looking at the content of these diversity statements and comparing whether or not the content was found on the REI Fellowship specific website or on the broader OBGYN related website for that individual group. And interestingly, diversity statements were only found on 8% of REI program websites, which is 4 out of 49 fellowships. The family planning people were doing a little bit better at 13%. MFM and Urogyn were at 10.7%. And GYN Oncology had the lowest number at 4.5%. There wasn't really a big geographic spread. Most regions in the United States had about a 30% rate in the different regions kind of examined. The lowest was actually in the Midwest, where you had 14%. So regarding the diversity statements on those 4 REI program websites, 3 of them, unfortunately, were pretty generic in nature, and only 1 of them had a focus on the inclusion of race and sexual and gender minorities. Which I think for a field that deals with human reproduction is probably what you want to be stating clearly for both patients, but applicants to your program, faculty for your program alike. Interestingly, 24.5% of REI program websites had a link to an external diversity statement that didn't exist within the REI fellowship. That was either affiliated with the hospital at large or the general OBGYN department website, but nothing specific to the REI program. So I think what to do with this is kind of the head scratcher, right? I think you read this article and you're like, okay, we're not doing a great job having diversity and inclusion statements on REI fellowship websites. If you take a step back and you think, do we need to be having diversity and inclusion statements on individual fellowship websites, or does the department speak on behalf of the fellowships? I don't know that I have the answer to that. I'm not sure that I'm expecting to see something different across every fellowship. I think it's reasonable to expect a department to have a stance on the topic. What do you guys think?
Two things. First, I gotta ask, and I don't want to ruin it because I'm sure a lot of people are like, oh, I'm gonna go read the article now to find out what that one center was. But would you spoil it for us? What was the one center?
I'm not at liberty to disclose.
Ah,
You'll have to go check out the website.
buy the book.
Fertstart.org, consider this. And you'll have to kind of read the nitty-gritty, see if you can find it out.
I'm glad that you're keeping them interested. But my actual question, I guess, would be it'd be really fascinating, not a question, but a comment, I guess. It'd be really fascinating to drill down a little bit on the data, if possible, to see if, what was it, 20% that you refer out even to institutional diversity statement, if there is increased diversity across whatever lines, be they racial or gender, if it's like meaningful in terms of recruiting a more broader range of physicians to that fellowship, because that's the goal, right? I mean, is the idea there that we want more broad representation amongst the providers. So it'd be interesting to see if these diversity statements really have any effect. The cynical side of me says that it's so boilerplate in modern society that everyone's got to have a diversity statement. And when you're reading the diversity statement, your thought process is, well, they got to have a diversity statement. I don't know how much meaning there is or how much that really represents what's going on in this practice, academic institute, whatever. So yeah, that's the cynical side of me, but I'd be really interested to see if diversity statements actually have an influence on the constitution of any fellowship or practice.
Yeah, I'd be interested in, does putting a diversity statement on your website mean that that's a focus of your department, or does it mean you're checking a box? And then, yes, how is the applicant perceiving it? Is it actually important for the applicant? Are they seeking these out, or are they actually just kind of like glancing over the CVs and the prior history of the current fellows and current faculty to decide if that's someplace that they want to be, or kind of getting word of mouth about how diverse particular division is? Probably a good idea for everyone to have one on their website, because it may look bad to not have one, I would say. But I also have noticed some fellowship websites haven't been updated in probably 10 or 20 years, based on when I applied most recently. And so if people are updating their website, definitely worth including.
Well, I can also say that regardless of whether or not these diversity statements are posted, I think I'm biased to my practice, but I've noticed a shift over the years as we've done our fellowship interviews that there's been a major emphasis placed on enriching the fellowship applicants as well as fellows, because we want something that mirrors, our patient population here in New York, while skewed significantly, of course. I think New York, like most places, has a very wide constellation of unmet need across many demographics. So that's what you want in your practice, right? You want your physicians to look like your patients so that they can speak to them and be heard, and also hear them. So I see the emphasis is there, whether or not the diversity statements are posted, at least in our own practice. And I wouldn't be surprised if that emphasis held across, most academic institutes, if not all fellowship programs.
I don't think in the history of diversity and inclusion statements, a diversity and inclusion statement has ever recruited a faculty or a fellow that otherwise would not have been recruited. I think it's the people in the culture that recruit talent to a program. And you got it exactly right. If they see people that look like them or a patient population that looks like them, they're going to gravitate towards there.
There is something to be said, though, that someone took the time to put it on the website, and then for the same reason, someone took the time to update the website. Okay, this is a program that's more paying attention, more trying to improve with the times. And I think all those little things may lead to an impression of a program. But I agree. I don't think that the statement's presence will make or break an applicant's impression of a program.
To your earlier point, though, Molly, is it there because it's a point of emphasis of that program? And,
Or is it checking a box?
well, or is it checking a box? And I think it's both, but I would also say that it should be the point of emphasis of every program. So it ought to be there. But what do I know?
Well, here's a call to action for everyone listening to the podcast. If you're involved in a fellowship program, go take a look at your website, see what you're doing, and maybe have the discussion at your next division meeting or fellowship program meeting, and pose the question: do we have one? Should we have one? And what are the pros and cons to having something written, but also just kind of living and breathing that diversity, equity, and inclusion ethos in your fellowship? So papers like this, I think, are cool because they're just not groundbreaking science, but has a conversation that gets started on the podcast, and also hopefully extends into your fellowship and division meetings. So thanks to the authors for submitting it. And as a reminder, consider this as that section that lives on the website. It's in front of the paywall, something that's imminently shareable on social media and with the lay press. And really what we're looking for your thoughts on new ideas, ethical points in our field, things that are happening outside of our field, and things that you think we should just be talking about in a non-structured primary research way. So we look forward to your submissions, and you can submit those on fertsturt.org. We have a Blake-sized hole at the end of the podcast that he normally would fill. So we'll have to all kind of scratch that itch next month. But we thank all of you guys for listening, and we'll see you in the month of July.
In the meantime, you do get the benefit of his amazing baseline, though. So you'll have to just take that with you.
And why don't we go ahead and cue it now?
This concludes our episode of Fertility and Sterility on Air, brought to you by Fertility and Sterility in conjunction with the American Society for Reproductive Medicine. This podcast is produced by Dr. Molly Cornfield and Dr. Adriana Wong. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.